Well, malignant self-regard is a personality construct that I have started to think more and more about as a syndrome. And the features of this are a sense of self that is often thought about as inadequate, is very pessimistic, tends to be self-critical. They get angry at themselves quite a bit, feel very disappointed. They tend to be very perfectionistic and achievement striving. Individuals with malignant self-regard can put themselves in situations that are kind of self-defeating for them. And as a result of all those things, they tend to become depressed. And sometimes they can become significantly depressed. But they will often present themselves in the clinic for this kind of depression and unhappiness. But as you get to know and understand a bit more about their personality and their history, you see this long-standing pattern of these personality characteristics that have been problematic for them for most of their life. The malignant self-regard construct was actually derived from several prior diagnoses that have been in the Diagnostic and Statistical Manual for the past several decades. So if you go back to 1980 and you look at DSM-3, there was a proposal of masochistic personality disorder. That was followed up by a proposal of a self-defeating personality disorder. And then in DSM-4 was the introduction of depressive personality disorder. None of those disorders subsequently were retained in the DSM system, but they had many similar features and characteristics, which led me to think about a common underpinning here among patients who present with this chronic depression, but yet seem to have certain similarities in their personality features. I've also incorporated some ideas from our study of narcissism into malignant self-regard because both of these conditions involve the way in which the self is represented in this sense of inadequacy. Well, both malignant self-regard and narcissism are problems and disorders that involve the way in which the self is experienced. Some have even gone on to talk about narcissism as a disorder of self-esteem regulation. And I would say that both malignant self-regard and narcissism share this feature in that the sense of the self really doesn't land in a stable and coherent place. In vulnerable narcissism, this is considered a subtype, or some say a phenotype of narcissism, in which individuals are identified who tend to be pervasively feeling inadequate. They're very hypersensitive to the criticism of others, and so their self-esteem regulates and fluctuates tremendously based upon how others think about them or perceive them. And so if they're criticized in some way, their self-esteem tends to get very deflated. In vulnerable narcissism, the clinical presentation is actually very similar to what you see in malignant self-regard, or even patients who would come in and might report that they've been depressed a lot of their life. And as you begin to understand them, you see that this pervasive inadequacy and pessimism is there, but you notice that there's quite a fragility to them in terms of their self-esteem, and that the slightest negative comment can hurt them. I do make a distinction, though, between patients with a pathology that's mostly narcissistic from those that are mostly malignant self-regard. In narcissism, and even those who have more of this vulnerable subtype or phenotype, you also tend to see elements of grandiosity that are present. So when you start to get into understanding these patients who have this inadequacy and are very hypersensitive, you start to see that underneath they talk about themselves and have ideas about themselves as being really special and under-recognized, and then you start to see elements of entitlement that are there and expectations of others. That's different than how malignant self-regard presents and the essence of that pathology. In malignant self-regard, you tend to see individuals who do have high expectations of themselves. They're very perfectionistic and they're very achievement striving, but you don't see a sense of maybe the entitlement or a hidden grandiosity. In fact, you see quite the opposite. You see these individuals saying that, you know, the grandiosity, I can't let myself think about this accomplishment or even speak favorably about something that I've done. That might appear as if I'm boasting or bragging, and I don't want to appear arrogant. And so there's a fundamental difference between these two constructs of like the vulnerable narcissism and the malignant self-regard. But certainly on the surface, when they present you, they would look very similar. And so it's important for the clinician to make some important differentiations in terms of those more kind of aspirational aspects of their personality and what's really motivating and driving that. Well, patients who present with malignant self-regard do pose certain treatment challenges. Because they come in oftentimes depressed, it's important to assess their level of depression, how severe it is, and how much it's been impairing them. My own work with patients has found that you know, a number of them tend to be dysphoric and unhappy, but the depression doesn't impair their everyday life to the extent that they can't carry out daily activities, or their, you know, the somatic symptoms are real strong. I've had other patients, though, where in the course of treatment, the depression does get worse. And so at times, psychiatric management seems to be in order. I have one patient who was not having a favorable response to psychotherapy and who elected to have more biologically oriented treatments of the depression. But unfortunately, that didn't work real well for him. And I continue to see that patient now, and we're still focusing much more on the personality characteristics. And I think really what's central to treating malignant self-regard is a focus on the personality characteristics as they're manifested in the self-representation and in the representation with others. So, you know, patients with malignant self-regard will certainly present themselves with, you know, this sort of level of inadequacy and perfectionism and just this chronic sense that, you know, they're just not getting anywhere. Nothing seems to satisfy them. And so you certainly hear a sense of self that is fairly inadequate and never quite good enough. And you hear a lot about others who seem to be doing better or who have their life together, or others who might be a little critical, and perhaps even others where some level of affection is desired from these individuals. The problem is that kind of rigid structure of self and other is set. And it leads the person then to always feel disappointed with themselves and in the relational world. I think what's real key, though, in treating these patients is to start to talk about what they're aspiring to, and that perfectionism and the achievement striving that they have. And to start to put those ideas and fantasies into the language and the discussion of the treatment. Because many times these patients will think, oh, I can't talk about this. I don't want to talk about my accomplishments or what I've done. It's kind of bragging. But I think it's real important for the patients to start to access this and to start to have language to talk about that and start to recognize this other part of their functioning, which tends to be going pretty well. And for a number of patients, they're very high achieving. I can think of one patient that I saw who actually was quite accomplished in her profession and actually rose up in her profession rather quickly. And one of the most therapeutically effective parts of the treatment was when we talked about those accomplishments and taking some satisfaction and joy in those, and to recognize that those too were a part of who she was. And as we started to look into why the inadequacy and why the sort of the perfectionism that was never satisfied, we certainly went back to early childhood and child-parent relationships to find aspects of the parent-child relationship that were problematic. So validation needs were not particularly met, untimely critical comments from parents that tended to, you know, work against her development of a more positive self-esteem. So I find that a big part of the treatment is to talk a lot about more of those underlying wishes and accomplishments, and to start to normalize them and include them into the patient's everyday life and representation of him or herself, so that there's room for both the more positive and achievement-striving aspects, as well as those things that are disappointing. And I do think that those are very central to having a successful treatment.